Hi, my name is Katrina Silva, and today I'll be presenting a 4-year-old female patient with ear fullness. So upon examining the patient, I'm going to tell my preceptor that I think she has one of two ear infections that are most commonly seen in pediatrics, which would be acute otitis media or otitis externa. And here I have some risk factors, signs and symptoms, otoscopic exam findings, and severities of these illnesses so that I can compare and contrast and decide which one she has. So starting off with acute otitis media, some of these risk factors include males being more at risk than females. It is seen in all ages, but this peaks at 6 to 24 months. And it's seen in younger children because of their immature anatomy of their eustachian tubes. These tend to be more horizontal and floppy in pediatric patients. They begin in the oropharynx and end in the middle ear, so if the child is sick, any kind of sinus fluids will kind of run into that middle ear area, causing acute otitis media. We also see this more prevalent in children who have a familial history of it, children who are in attendance of daycare, children that are exposed to tobacco or air pollution, children that use pacifiers, which is a big one. We also see this more often in the fall and the winter, as well as in certain races. So any kind of Native American children, Alaskan, Canadian, Inuit children, as well as Indigenous Australian and Greenland children. We also may see this more common in children that have limited resource environments, especially medical limited resources, as well as children who live in homes that make them more prone to getting sick and then acquiring the acute otitis media. And then we also see this in children with a decreased immunity, which kind of ties into the limited resource. So those kids that are sick with either allergic rhinitis or just rhinitis itself, children that have HIV, children with cleft palate or Down syndrome are also more at risk. And then comparing this to otitis externa, we see this more in childhood, especially in the summertime, children that are swimming or exposed to water, and this is due to the breakdown of the cerumen skin barrier. It changes the normal flora within the ear canal, making it predominantly gram-negative bacteria and causing otitis externa. We also see this in children with excessive cleaning, scratching, Q-tip use. We want to be cognizant of making sure there's no extra little pieces of cotton in the ear canal, because this serves as a great bacterial medium for bacteria to thrive in. And any kind of occlusion of the ear canal puts you at risk for otitis externa. So in children, this could be a diving cap while they're swimming, or if they're using earphones a lot. In older adults, we could see this with hearing aids as well, but our child is 4, so she probably doesn't have that. We also see this in children with more allergies, contact dermatitis, psoriasis, and atopic dermatitis, as well as children who have had radiation therapy. This changes the epithelium within the eardrum, causing ischemic changes and putting them more at risk for otitis externa. So as we take a peek at the signs and symptoms, you're going to see for acute otitis media some pain, hearing loss, rubbing, drainage may be possible. You're going to see fever in 1/3 to 2/3 of these patients. If this fever is greater than 40 degrees Celsius, we want to start questioning bacteremia as the underlying cause for acute otitis media, because it's not typical to see that high of a fever with uncomplicated acute otitis media. We may also see decrease in sleep, decrease in eating habits, and nausea, vomiting, diarrhea in these children. And comparing over here, you're going to see a lot of the same signs and symptoms in this, which is why I have the otoscopic exam separate, because it's such an important step for us to do as the FNP to really determine what disease process is going on here. The signs and symptoms are not enough for us to know. So you're going to be seeing also pain and hearing loss in otitis externa. You may also see drainage as well. You can have pruritus and tenderness upon the tragal pressure as well as auricle manipulation of the ear. And in severe cases, these children can have fever and lymphadenopathy. So this otoscopic exam, super important for us to do. When we're looking at acute otitis media, we're going to be examining the tympanic membrane. And one of the hallmark signs of acute otitis media is the bulging of the eardrum, as well as inflammation. And the reason that this otoscopic exam is so important is a child can have otitis media with effusion and not have it be acute otitis media. So these findings are what is going to separate it. Like an opaque yellow eardrum, a typical tympanic membrane is kind of a translucent gray, pearly, blue color. And if it's opaque yellow and white, we know that there's purulent drainage behind the tympanic membrane. You may even see perforation in the ear and in the eardrum tympanic membrane. If we see that, the patient might not be in as much pain anymore because this perforation occurred. It kind of is a big release of all that pressure that was built up behind the tympanic membrane. Another part of this exam is the pneumatic otoscopy. You want to create a seal in the eardrum, and with a blood pressure like pump, you're going to squeeze in and out, causing positive, negative pressure, and this is going to move the eardrum back and forth. So a healthy eardrum is going to move in and out, and in acute otitis media, you're going to see a huge decrease or complete loss of movement. So over to otitis externa. We're going to have an edematous ear canal. It's going to be super red and erythematous. We're going to see debris most likely in that ear canal, and you want to take note of the color. If we're seeing white debris, it could be fungal, meaning candida, and if it's a dark color, it could be aspergillus. So it's important to note that. And upon pneumatic otoscopy, this membrane will be movable because the infection is not behind the tympanic membrane, it's in the ear canal. You may see membrane rupture in otitis externa, and if so, you want to make sure that this is not secondary to acute otitis media, because what can happen is that buildup of pressure will perforate the patient's tympanic membrane, and that drainage will leak into the ear canal, causing an infection there and then causing otitis externa. So with all of these things taken into consideration, I'm going to do a health history and physical exam on my patient. I'm going to ask mom and the patient some questions. And let's just say, for the sake of this case, that mom is telling me that the patient woke up with a relatively rapid onset of pain and discomfort in her right ear 3 days ago. This has been going on for 3 days. The patient can't do a pain scale for us, a numeric pain scale, because she's 4, but we'll use the FACES pain scale, and we'll say that she lands at a 5 to 7 range of pain. She's telling me it's itchy, it's uncomfortable, it hurts, and mom tells me there's been no relieving factors, but it does hurt her more when she touches the outside of her daughter's ear. We're also going to ask her if the pain is anywhere else, if it's radiating, and she says no, as well as if this is intermittent or constant, and they're telling us that it's constant. So with all of that information taken into consideration, I'm going to tell my preceptor that I believe this is otitis externa. And looking at the severity as the FNP, this is pretty important because we're going to decide if this patient needs an elevated level of care. So both of these illnesses have a spectrum of mild to severe. With acute otitis media, if we are seeing a more severe case with that super high temperature of greater than 40 degrees Celsius, we want to call emergency services to take this patient to the hospital because we are going to be questioning bacteremia. And for otitis externa, in those more severe cases, we want to be making sure that we're looking for a membrane rupture in the otoscopic exam to make sure that this isn't secondary to acute otitis media. And we really want to make sure we're fully aware of those underlying causes with a good health history. So yeah, I believe that this patient has otitis externa.